Ladies and gentlemen, good evening. It is an honor and my pleasure to be the chair of this pain symposium of Day of Department of Anesthesia, ICU, and Pain Management, Cairo University. This day is in collaboration with MEGA Online Anesthesiology course by Dr. Saad. Today we have 6 speakers, all from our department, Anesthesia, ICU, and Pain Management Faculty of Medicine, Cairo University. According to their presentations, first is Dr. Ahmed Zaghloul, Professor of Anesthesia, ICU, and Pain Management.
In this lecture, I'll talk about the regional anesthesia for trauma patients and does it improve the outcome or not. My objectives in the lecture are to discuss the role of regional anesthesia within the overall framework of patients, of pain management in trauma patients, to give examples of where regional anesthesia may affect the outcome in specific injuries, and to address briefly some controversial conditions as acute compartmental syndrome in the context of neural blockade. As you know, that trauma is a significant health problem and the leading cause of death in all age groups. And the problem is that trauma is usually associated with severe pain. And if this pain is not adequately treated, this will lead to the development of chronic pain. So in this article, which the authors tried to determine the risk factors of the transition from acute to chronic pain in post-traumatic patients, they reported that up to 77% of the patients with severe musculoskeletal trauma will report post-traumatic chronic pain, which is defined as pain that lasts greater than 3 months from the time of injury. So what are the barriers that prevent clinicians from doing an effective management or pain management to the acute pain associated with trauma? We have barriers that may be related to clinicians or to the patients. Clinicians are usually reluctant to give pain therapies such as opioids to such population because they are usually afraid of provoking respiratory depression and airway compromise, or also they are afraid from hemodynamic instability. They usually give priority to resuscitation and assessment and treatment of the life-threatening injuries. Also, we have barriers that may be present in the patients, especially those with neurological injury, because they usually need frequent reassessment, which may be impaired or obscured with systemic opioids. Also, they may be unable to communicate adequately due to the need for sedation or mechanical ventilation. So as you know that opioids are excellent analgesics and they are the most common approach to pain management in trauma patients. Opioids work quickly and are a rational choice when patients present with multiple injuries. However, opioids have many side effects, and the most serious are the provision of respiratory depression and hemodynamic instability and sedation, especially in this group of patients. And this will be the rationale for the use of regional anesthesia in trauma patients. Regional anesthesia may provide superior analgesia, may decrease the stress response, increase alertness and patient cooperation, decrease the systemic side effects, prevent from the development of chronic pain. Also, by regional anesthesia, we avoid induction of general anesthesia and its sequelae. We can apply this for upper and lower limb trauma and thoraco-abdominal trauma. For upper limb trauma, we can do brachial plexus block, and this is the anatomy of the brachial plexus. We can do the block at various sites. We can block the roots, the trunks, divisions, and cords. Above the clavicle, we have, as you know, we can do interscalene or supraclavicular block. Interscalene block suitable for surgery on the shoulder and the upper arm. Supraclavicular block will be suitable for humeral, elbow, for arm and hand surgery. Below the clavicle, we can do infraclavicular or axillary block, which is suitable for the elbow, for arm and hand surgery. In this study, they tried to investigate or to compare between ultrasound-guided axillary brachial plexus block versus general anesthesia in upper limb trauma surgery. And you can see the difference between the two. In the ultrasound group, there is a significant decrease in the pain score, as you see, at rest and 2 and 6 hours. Also, for morphine consumption, there is a significant decrease in the ultrasound group when compared to general anesthesia, up to 24 hours. They reported that ultrasound-guided axillary block provide excellent anesthesia, superior analgesia, and reduced opiate consumption and facilitated recovery room bypass. We have a question here. Patient presented with shoulder dislocation. So which type of anesthesia do you prefer for these patients? You can give this patient regional anesthesia, or you prefer to give him deep procedural sedation. This question is answered by the authors who performed this study. They compared between the procedural sedation and ultrasound-guided interscalene nerve block for shoulder reduction. And they reported that ultrasound-guided interscalene block spent less time in the emergency department and required less one-on-one healthcare provider time compared to those receiving procedural sedation. For upper limb trauma, we can also do peripheral nerve blocks as radial, ulnar, and medial nerve blocks. And this will be suitable for hand surgery. And we can do these blocks also to supplement partial higher blocks. However, the drawbacks will be the pain that will be associated with the tourniquet use. And we can overcome this by using blocking the intercostal brachial nerve, which is very easy by infiltration of the upper third of the medial part of the arm. Also, another drawback is the need for injection at multiple sites, which may in order to do complete anesthesia, and this makes these blocks are rarely performed in practice. Third block, we can do intravenous regional anesthesia for upper limb trauma. This will be suitable for forearm, hand, and finger procedures. However, the limitations will be, as I said, also pain secondary to the tourniquet, short duration of anesthesia, toxicity if basic precautions are not followed, and the lack of postoperative analgesia. This study, they compared between the single cuff forearm tourniquet and the upper arm tourniquet. For forearm tourniquet, nearly we use the half the dose that can be used for upper arm tourniquet. You can see that with the forearm tourniquet, there will be less discomfort and fewer sedation interventions and a greater likelihood of bypassing the vacuum when compared with upper arm tourniquet. Second thing is lower limb trauma. For lower limb trauma, we can use neuroaxial techniques, lumbar and sacral plexus blocks, compartment block at the fascia iliaca block, and the peripheral nerve blocks as femoral, sciatic, popliteal, and so on. I take the hip fractures as an example, as they are very common injury. Also, the patients with hip fractures tend to be older with multiple medical comorbidities. So when we revise the innervation of the hip joint and the femur, you can see that the femoral nerve innervates most of the head of hip joint and the femur part from the medial part is innervated by the obturator nerve, and part of the posteriorly is innervated by the sciatic nerve. This is systematic review, which included 83 studies addressing various analgesic options for hip fractures, including systemic analgesia, traction, multimodal pain management, and neurostimulation. The blocks used here are 3-in-1 nerve blocks, epidural analgesia, fascia iliaca nerve blocks, femoral nerve block, and psoas compartment. As you see, there was no significant change regarding the 3-in-1 block and fascia iliaca block. However, the epidural analgesia and femoral nerve block and psoas compartment, there was significant reduction in the VAS score. This article, which compared the perioperative nerve stimulator guided femoral nerve block and the fascia iliaca compartment block in patients with femoral neck fracture, there was a reduction in the mean VAS score in favor of the femoral nerve block, and also the morphine consumption was reduced in femoral nerve block when compared with the fascia iliaca block. This is a recent block, which is a perivascular nerve group block, and in this block, we target the articular branches of the main three nerves that supply the hip joints, which are the femoral, sciatic, and the obturator nerve. And the advantage of this block will be that we can do sensory block without motor block, so it will be associated with motor sparing. And I think it will be better than the other blocks, as the patient we can do early ambulation for the patient after surgery. The third part will be the thoraco-abdominal trauma, and I take the rib fractures as an example, as the fractures are associated with severe pain, and also they may cause limitation of respiration and respiratory compromise. And it was reported that epidural analgesia may improve clinical significant outcome, and it should be considered the preferred analgesic option. However, thoracic paravertebral block, when compared with the thoracic epidural analgesia in unilateral multiple fracture ribs, both techniques were equivalent with respect to the pain relief and the improvement in the respiratory function. These are two blocks which I think they are safer, easier than thoracic epidural and paravertebral. The first is the rectal spiny block, where we can deposit the local anesthetic deep to the rectal spiny muscle, and the more recent is the retrolaminar block, where we can deposit the local anesthetic between the lamina and the transverso spinalis muscle. These two blocks are easy blocks, safe and effective for chest analgesia. We can also use the catheter to provide continuous peripheral nerve blocks when we need to prolonged analgesia, and in complex injuries that require repeated debridement and fracture fixation, also skin grafting frequently. Controversies, as I said, we have conditions where the use of regional anesthesia may be controversial in trauma patients. It was thought that it may add risk to trauma patients. I have three main conditions: the acute compartment syndrome, the pre-existing nerve injury, and coagulopathy. Compartment syndrome, we mean by this is the increased pressure in a closed space that overcome the capillary perfusion pressure and causing circulatory and tissue dysfunction. So this is what happens in compartment syndrome. Soft tissue extremity injury, will cause intercompartmental swelling. This will cause capillary collapse and will stop flow through the tissue bed. This will cause tissue hypoxia and capillary vasodilatation. So this will lead to leakage that will cause edema and increase swelling, and so the patient enter into a vicious circle. These are the manifestations associated with the compartment syndrome: pain, paresthesia. Pain will be distal to the surgical site, and there will be motor weakness which may result from compression of the nerve crossing the affected compartment. So the question will be that, can we give regional anesthesia for the patient or not, as regional anesthesia will eliminate pain, which is a presenting symptom, and this will mask the developing syndrome. So this is a systematic review which discuss the clinical findings. Are they predictive of the disorder or not for the diagnosis of compartment syndrome? You can see this, the sensitivity and the positive predictive value for the signs and the symptoms are from 13 to 19%, which means that the absence of these clinical features are more useful for excluding the diagnosis than its presence to provide positive diagnosis. Also, this is a more recent systematic review discussing the same issue, the acute compartment syndrome of the lower limb and the effect of postoperative analgesia on diagnosis, and they reported that there is no convincing evidence that patient-controlled analgesia and regional analgesia delay the diagnosis of compartment syndrome. So we can use a regional anesthesia in this type of patient, but with certain precautions. We should avoid dense and long-acting neural blocks. Better to use the peripheral nerve approaches, and we should use short-acting local anesthetic policies for operative procedures. The second controversial condition is pre-existing nerve injury. Patients with pre-existing nerve lesions are more susceptible to further injury when exposed to secondary insult. And the controversy here is that while the risk may be conferred through the needle trauma, but with a block, the resulting sympathetic block may improve the neurovascular compromise in the unaffected extremity. So we can also use regional anesthesia with certain precautions. Better to use less potent local anesthetics, reducing the volume and concentration, avoiding vasoconstrictors, and avoid other causes of secondary nerve injury as tight casts, patient positioning, and arterial hypotension. This is very important for medical legal purposes. Before the block performance, detailed neurological examination and documentation should be done. Coagulopathy, and as you know that trauma predisposed to both bleeding and thrombosis. So in the presence of coagulopathy, neuroaxial techniques are better to be avoided, as they may be associated with serious complications, and the most important is provision of epidural hematoma. And it was preferred that superficial approach to peripheral nerves and avoidance of vascular structures under ultrasound guidance better to be used. These are the limitations of regional anesthesia and trauma. Regional anesthesia may considered as direct competition with ADLS resuscitation, may cause direct harm, as in neuroaxial anesthesia in patients with increased intracranial pressure, may add to cause expansion of the extradural hematoma or epidural hematoma. Injuries mandating general anesthesia for definition of the surgical treatment, inability to position the patient for procedure, and when consent cannot reliably be obtained. To sum up, regional anesthesia confers a variety of benefits to trauma patients. With appropriate patient selection and management, such intervention are effective and safe. Thank you.
Thank you, Dr. Ahmed Zaghloul.
Thank you, Dr. Muhammad.
Thank you, Dr. Ahmed. It's a very nice talk and very clear. Just I have a small comment that documentation of the condition of the patient before, in trauma patients especially, before any application of any regional blocks must be documented, as you said, but must be signed by the patient or one of his relatives and by the nurse and one of the assistant for you, because this may be a sort of claim after that.
Thank you, Dr. Muhammad.
Dr. Maher.
For this comment. Thank you, Dr. Maher, for this comment. Sorry. Usually we learn from you about these medical legal issues. You are mastering these issues, Dr. Maher. Thank you again.
Dr. Saad, you have...
Can I add a comment, Dr. Maher?
Okay.
Dr. Ahmed Zaghloul mentioned the pinch block. Now there is a tendency to block the nerves at their end, at the periphery of the nerve, so there is no motor or sensory block. For the hip, the pinch block is increasing. For the posterior side of the knee, the IPAC block has been used for the same purpose. Thank you.
Thank you, Dr. Muhammad.
There is a question from the floor. What about the retrolaminar block?
Retrolaminar block is a block where we can deposit the local anesthetic above the lamina. If we imagine the erectrospinal block, so we can, with ultrasound, moving more medial to get the lamina, and then we insert or deposit the local anesthetic just above the lamina. So it was theoretically or logical that it will spread to the paravertebral space than the erectrospinal block.
Do you think that it's safe enough like electrospiny?
Dr. Ahmed, can I add a comment on this?
Okay.
Dr. Saad, if we look, the erectrospinal muscle is lying from the spinous process and goes laterally, so it sits on the lamina and on the transversal process. The erectrospinal muscles is not a one muscle, this is a group of 3 muscles, okay? So it depends where you are going to deposit your local anesthetics. So the retrolaminar, it is a one form of erectrospinal plane block, okay? So whether you are going to locate your local anesthetic in erectrospinal block, whether medial or lateral, it will go and will soak the paravertebral space. So we prefer to call it an indirect paravertebral block. The difficulty is in the space between the muscles and the bones. I mean, sometimes when you go medial, okay, the space between the muscles and the bone is very tiny and you cannot inject your local anesthetics. But it is a form of a paravertebral, of erectrospinal plane block.
Okay, thank you.
Yeah, I have a comment. In order to say, is it safe to as a erectrospinal block or not, this needs more studies. But for one who can use the ultrasound and can see the needle, I think it will be safe, as you have an endpoint which is the bone, either in erectrospinal block and in retrolaminar block. When compared with paravertebral block and with the thoracic epidural, it will be safer than these two. But for electrospinal block, we need more further studies to assign this issue.
Okay, thank you so much for that. And we would like to keep the discussion a little bit crispy.